Welcome to the Transfusion Practitioners Investigate Audit and Data for Change workshop. It's our pleasure to be with you this evening, for me here in Australia, and for those people in the Northern Hemisphere in the morning. I'm Linley Bielby, and I'm the International Society of Blood Transfusion Practitioner Forum Chair. And today I'm going to be presenting with my colleague Jana here, Jana van der Broeck from Belgium. And in the background we've got Rachel Moss and Claire O'Reilly that are going to be supporting us today. You might wonder about the icon that we have in the corner, or our graphic. This is an image of an oak tree, and it symbolises strength and endurance. And with an acorn comes unlimited potential, that out of something small, something large can grow. And this is the aim of our Transfusion Practitioner Forum, that with strength and endurance from little things, big things can grow, and we want to hopefully take you along on our journey with us. Today's going to be an interactive session, and we're going to be using polling. So if you haven't already found that, that's on the top right-hand corner of your screen. And so when we talk about the polls, make sure you're in that so that you can actually participate in the poll. We'll also be using the chat, and if you've got any questions, we encourage you to actually use the Q&A tab that's there as well. As you can see, some people have been using the emojis, and we welcome those throughout the session. We'd love to see you interacting with us. So some of our transfusion practitioner group will be monitoring our chat, and some of them might be answering the questions online, or we will certainly have some time at the end of our session where we can answer some of your questions. So next, thank you, Jana. So I guess it's really important for us to explain the context, or what is a TP. So it's not really straightforward. The term TP actually started in the United Kingdom, and we now use it internationally to describe a lot of varied activities that are undertaken by a group or a variety of health professionals whose key role is supporting safe and appropriate blood management or transfusion care for patients. There's significant variation in the staff specialties that fulfil the role. Some of the common terms that you might hear around the different countries are transfusion nurse, transfusion safety officer, quality officer, or a haemovigilance officer or haemovigilance nurse, transfusion nurse consultant, patient blood management coordinator, or a blood management nurse. Just come from many different backgrounds, healthcare backgrounds. They're mostly in nursing, but there's quite a number that have scientific backgrounds as well. And in some countries, we have medical staff that are actually undertaking some of the roles. So as you can see, that's quite a diverse skill set. Transfusion practitioners are usually clinically based and not lab-based, and they complement transfusion or patient blood management, medical and ward-based nursing roles. The roles are pretty well established in a number of countries, such as in the UK, Ireland, Netherlands, in Canada, in Australia, in New Zealand, Singapore, and in Belgium. So the next slide will show you really about what the role of our Transfusion Practitioner Forum is. It's really to try and promote the role and the value of transfusion practitioners within the international PBM initiatives. So, and to promote the role at ISBT and at congresses. We're very pleased that ISBT has really been embracing of the transfusion practitioner role and really encouraging its growth and supporting us in a great way. We also be wanting the transfusion practitioner group to provide tools and evidence to actually help support implementing blood management initiatives, to provide a platform where we can actually collaborate with our international colleagues, and to provide resources to support transfusion practitioners or developing practitioners in their workplace. And we've been very pleased to know that with the work that we've done with some of our colleagues internationally, that we've actually been able to help them establish and support new roles for transfusion practitioners. So here we can see a bit of a pictorial view of some of the activities that a transfusion practitioner could undertake. The transfusion practitioner skills are really quite varied depending on what their background is and what the strategic direction of the organisation is and where they work. They are seen as a bridge between the laboratory and wards. Their goal is to improve quality and safety of transfusion and blood management, along with supporting implementation of PBM. So you can see in here that the activities could be education, so they could be educating their peers or providing patient information. They could be involved in policy and procedure development. It could be the development, implementation, and then compliance monitoring. They could be involved in audit, which we're going to be talking about, and that audit could cover lots of different things, such as blood usage. Are people using blood according to guidelines? Are they documenting use appropriately? Are they adhering to the policies and procedures that you've got in place? Are people doing consent? And what about anaemia assessment? And haemovigilance is another area, and you've probably just heard us, if you're at the previous workshop, about adverse or event and incident investigation is another area that transfusion practitioners are actively involved in. Some patient blood management activities such as anaemia assessment or management or reducing iatrogenic anaemia are also areas where people will work. So now we're going to have our first poll. So our first poll here today is just to try and find out who is actually at the forum. So if you could help us by participating, so select which is the most appropriate description for you. So a transfusion practitioner, a transfusion nurse, a transfusion quality or safety officer, a haemovigilance officer or nurse, a transfusion clinical nurse consultant, a patient blood management coordinator or practitioner. Are you a transfusion medicine doctor? Are you a laboratory scientist or a nurse? Or if you've got some other things, you could add that to the chat. So we'll just wait until all these votes come in and we can see what kind of audience we have here with us today. So I can see here we've got quite a varied audience. We've got 5% of transfusion practitioners, 10% are quality officers, 10% haemovigilance, and we've got 38% of haemovigilance transfusion medicine doctors, so thank you for coming along, and 29% of laboratory scientists, and 10% of others that have probably added those comments to the chat. So thanks for everyone. It gives us a really good idea of who's actually being involved. So we've also now got another polling question. And we'd like to know if you are currently involved in audit or data collection. So if you could tell us or select which one of these fits yours. So if you are involved with audit and data collection, you're not involved or you're not sure, if you could indicate those there for us now, and we can see what kind of activities you might undertake in your roles. And it's just closing now. So we've got the vast majority of 77% who are actually involved in audit and data collection. So that's really great. So I guess just to reiterate the learning outcomes from today is we really want to be able to provide you with some working examples of how we can demonstrate how audit and data can be used to plan and implement change. We also want you to gain knowledge about the freely available international resources that could be used around audit and data collection. And we also want you to be able to gain an understanding of the role that the transfusion practitioner plays in actually undertaking audit or data collection and helping to implement change. So here is something that's been taken from our position description template that's currently available on the ISBT Transfusion Practitioner webpage. We've put together a whole template for position descriptions covering the 3 different areas of transfusion practitioners. So someone who's a novice, someone who's an experienced practitioner, or someone who's in the senior practitioner role. And here you can see this actually highlights what aspects of audit each one of those roles could be involved with. So we've put this template together just to help health services to develop position descriptions for their either new transfusion practitioners or to extend the role of someone in their organisation. So this is available through the ISBT website if you'd like to review that. So the value of audit. Well, audit helps us understand what the current situation is in an organisation. It helps us to look at the gaps between practice and the targets that we might have set, or it helps us establish targets once we have actually explored the audit results. It helps us report on performance. It helps us to identify variations that might be happening between clinicians or between clinical specialties. It identifies areas for improvement, and it helps us support the need for change. The data can be collected from everywhere. It could be a really easy or quick audit. We could collect just some easy data that's easily available, or it could be complicated. It could be linking databases, which you might hear people referring to as about big data. So today we're going to explore, I guess, the process of audit and then implementing that data and helping us implement change. So here you can see the PDSA cycle. So this is one of the methodologies, and there are many that can be used as a framework for audit. The PDSA is a 4-step management method. It's been commonly used in business to help control and undertake continual improvement for processes and products. It's been adapted by healthcare and as a quality framework. It's internationally recognised, and it is part of the Institute of Healthcare Improvement model for improvement. To many of you, you may have already been familiar with the PDSA cycle, but for others it might actually be something new. It's really a shorthand testing process for change. It's where you can develop a plan and test it, that you can carry out the test, so you can do the doing, and you can observe the learnings or the consequences, so you can study those. And then you can determine what modifications should be made, so the acting part. So we're going to use the PDSA cycle today as part of our workshop and work through each one of those steps. Thanks, Jana. So our original problem is that our blood management committee wants us to check and see if and how many patients are going to surgery that are anaemic. We're wanting to especially look at the surgical procedures in which substantial blood loss is anticipated. So they could be in orthopedics, in major joint replacements. They could be in gastro, in either upper or lower. Could be gynae or cardiothoracics. But today we're going to be looking at a bit of an example in relation to orthopedics. So why is it important for us to identify anaemia and manage it? Well, it's important for us to optimise the patient's own red blood cell mass. By doing this, we actually improve patient outcomes. We reduce the length of stay. We reduce the need and the exposure to allogeneic transfusions and all of its associated risks. It can help to reduce any delays in elective surgery that might occur. Thanks, Jana. The commonest cause of anaemia is iron deficiency, and iron deficiency and iron deficiency anemia have a significant impact on health and well-being. This template that you can see here is from the Australian Patient Blood Management Guidelines for perioperative management of perioperative anemia. It shows the different types of anemia and the suggested management for each of them there. You can show in its areas, it will have the first box, which looks at iron deficiency anemia, and then the next one, and it also then discusses some of the management things that you might like to do once it's discovered after doing all of the pre-workup here. It also talks about iron deficiency, then it also talks about anemia of chronic disease or inflammation. So it shows you that there are different areas of anemia and there are different ways of managing each one of those. Thanks, Jana. So our first part of the PDSA is planning. So at the planning stage, we need to look at planning what data we might be going to be collecting. And the data collection environment will vary depending where you work. So you need to actually understand your own organisation and the patient flow from seeing the surgeon through to the actual surgery to know where some of the data will be able to be collected. So what to collect? So what information is going to help you answer the question that you've actually got? Where could you collect this information from? So what systems do you have that you can access? what part of the medical notes would you be looking at to include the information that you want to gather? How are you going to collect it? So are you going to be using an audit tool? Is it a paper and pen audit tool, or perhaps is it an electronic tool? How are you going to record it? So you have a record, so it's good to always keep a record of the data that you're collecting so that you can actually go back and refer to that, particularly if you get questions asked. Who's going to collect it? So will it be you, or will it be a colleague? And are you able to pull some of the reports that contain the information already? Is it readily available? And what kind of time frame are you going to be looking at? So you need to be thinking about how much data you need to collect to indicate that there might be a problem. So this could be a week's worth of data, or it could be a month, depending on the situation. Say in a surgical setting, if you have a high throughput, you might only want to have a short time frame. If you do less types of surgery, then you might want to have a longer time frame so you capture more data. And who are you going to report it back to? So initially, considering this was the Blood Management Committee that's asked us, we're going to be reporting back to them. And then we'll probably be getting them to take that further so that we can actually action some of the data or the results that we find. And we're going to talk about this a little further on. We've got another polling question here for you now. And so this one's quite a long question, so I'll go through it. So you can select as many that you'd like to apply here. So what data would you collect? So we'll just get our polling question up if we can. Thanks very much, Noy. So what data are you going to collect? Are you going to be collecting the date of surgery and the procedure? Are you going to collect did the patient attend a preoperative clinic and when they did? Preoperative hemoglobin or iron studies, including ferritin? Are we going to be collecting the time that the blood test was taken in relation to surgery, or any preoperative treatments, any intraoperative blood loss, interoperative treatments, postoperative hemoglobin, or postoperative treatments and discharge plans? So we've got a few more seconds there that people can actually look at. You can select as many as you think would apply, depending on how vast you wanted your audit to be. You might only want to collect some of those areas. If we were looking at the preoperative anaemia, you may not want to collect some of the postoperative stuff. Or again, you might. So here we go. We've got 14% wanted to collect the date of surgery, 9% if they've attended a preoperative clinic, 13% about their blood tests, and the timing was 12%. 12% wanted to know if they had any medications or preoperative treatments, 9% about intraoperative blood loss, 10% about interoperative treatments, and 10% postoperative HB, and 9% the postoperative treatments and discharge plans. Well, thank you everyone for that. Now we'll actually just move on to another question in relation to polling. So if we can have that next question. This one's really looking about how and what kind of data you would collect. So how would you collect it? Would it be paper-based? Would you be using a spreadsheet? Would you be using an audit tool that might be publicly available? Do you have specific audit software that you could use? Would you be collecting it from your hospital and laboratory information systems, patient records, whether they be paper or electronic, or perhaps you might have other things that you might like to add to the chat. So we've just got a few more seconds left there for people to vote, and you can select as many as you wish. And unfortunately, we didn't put all of the above, which we could have to make it easier for everybody. Okay, so here we go. Some people, there's 5% paper-based, 10% for a spreadsheet, 12% using an audit tool, both publicly available or software. 31% would be looking at the hospital and laboratory information systems. 29% would be using the patient records, and 2% may have added some other stuff into the chat for us. So I guess how and where we collect data will actually be influenced by our own environment that we have. So some tips to actually identify data or the indicators for data and to provide feedback. It's important to actually have evidence that supports the reason that we're doing the audit and what data that we could collect. So clearly in and around the area of anaemia management or anaemia assessment, there is actually lots of peer-reviewed literature there that can help us support this and provides evidence for what we're actually looking at doing in this audit. We can align the data that we collect with goals and priorities for our department. So clearly this is going to be aligned with what our blood management committee wants to do, and they then may develop targets in relation to that. To help audits work well and to make the most of the data that we collect, we should be designing with the stakeholders that are going to be involved in it. It'll actually help us identify any variations in practice or any low baseline performance. And in some settings, it might actually just help us set our baseline to see where we're at, and so we can then measure our improvements. When we're providing feedback, where possible, it's good to be able to provide individual feedback and data rather than just aggregate data. Sometimes that's not always possible because it will be too identifying. But depending on the specific situation, if we can provide individuals, that is good. And if we can have a metric that's within the individual's control, it then makes them, I guess, owns the process much more. And so they are capable and responsible and feel engaged with the improvement. The data does need to be valid, so you need to have actual solid mechanisms in which collecting that data. And the data needs to be based on recent performance for people to actually, I guess, make it useful to them. So again, the amount of data that we collect and the time frame. So we might be having a snapshot. So it could be depending on the resources and the size of the health service. You might just want to do a small snapshot or use a larger population. And like I mentioned before, the time frame could be for 1 week or one specialty, or all specialties, or it could be all patients in a month. So now we've got another polling question in relation to what are your data challenges. So select all of that apply here. So are your challenges that you just don't know where to start, that you have lack of staff, that you have lack of time, that you have poor IT systems, that you don't have access to the data? You might not have permissions to access the data, or the results might be in a private physician's room or at a different hospital. Do you feel that you don't have skills as a data collector, or if there's others that you can add to the chat? So we've got a few more seconds left there if people want to select, and select as many as you think apply. And we'll have a look at those. Just a few more seconds. Okay, so we've got a variety of things. So some people are not sure where to start. We've got 17% with lack of staff, and lack of time is 19%. And poor IT systems is 17%, 19% to access the data, and 17% about the skills. So there's a real mix of things there, and I guess many of us would identify with a lot of those responses. So the doing. The next part of the PDSA cycle is we need to be able to collect the data. So we need to consider the challenges and how we might overcome that. So the challenges would include accessing the test results. Do you have multiple pathologies? Is the data kept outside of the organisation? Are there lots of different IT systems that you have to access? To help you overcome the barriers, you might seek help from a colleague. You might have colleagues in other departments. You might have an IT guru that can help you. You might have your mentor or your direct report that can actually help you overcome some of the barriers that you might have. And acknowledge that due to limitations, sometimes we can't always get all the data we want, and that might be an issue in some health services. Now, this next slide that you're going to see is a pre-populated data set. This is using a simple audit tool that is available for use. This is an audit tool that's available on the Blood Matters webpage, and it looks at anaemia where we're measuring hemoglobin. And as you can see, it doesn't actually collect information about iron studies or the additional CRPs or renal studies in this. This is a very simple hemoglobin only. But you may wish to include some of those other studies if you are doing it yourself. The template will populate a report, and we're going to look at that in a little while. So after we've collected the data, then we need to study it. We need to set aside some time to actually analyse the data and to study the results. And now we're going to see some of the results of the populated report that was shown you previously. And looking at the data, what trends can you actually see? So we've actually got a number of issues here in this small amount of data that we've collected. We've only got 47% of the patients that attended a pre-assessment with less than 4 weeks to surgery, and 50% of those attending having blood results available. 57% only had a full blood count less than 4 weeks, and so therefore missing the opportunity to assess and treat any potential anaemia in a timely manner. 23 of the 30 patients were anemic, and only 4 of those received treatment preoperatively. 5 patients had a transfusion when perhaps other treatments may have been more appropriate and reduced the risk of a patient needing a transfusion. So now we're armed with the results. We need to think about moving to the next step of the cycle, which is the ACT cycle. And this is where I'm going to hand over to my colleague Jana, and she's going to take you through the ACT components. So thanks, Jana.
So next in the PDSA cycle is the ACT phase, where you feedback your data. It's important to tailor the feedback to the target audience and local context. Try to get to know more about the recipients of the feedback. How engaged were they in the audit process? What are their goals and the goals of their team? What is their professional background? And how about the setting? What are the available resources to act on feedback? What is the size of the team? Are other actions taken to support the feedback? For example, incentives, penalties? Are there some tools available? Is there education provided? It's important to be aware of the hospital culture of feedback. Is there a culture where one can feel safe to receive feedback and have an opportunity for reflection? So here is another question we would like to ask in the poll. What methods would you use to feedback data to your blood management committee? So again, you can tick off several answers. Do you use graphs, tables, or infographics maybe? Do you use a written report, PowerPoint presentation, dynamic dashboard, or maybe some other? So please answer the poll so we can have a look together. Some seconds left, and then we will have a look to the results. So we have 23% that have chosen graphs, 14% is using infographics, and 21% is also using written reports, 17% PowerPoint presentations, 4% dynamic dashboards, the most advanced one, but really nice. Okay, then I would like to ask you another question. How might you communicate this to the broader organization? So you can choose several answers again. Presentations, infographic, posted on the organization's intranet, use the organization's social platforms, at meetings with clinical groups, or other. So the other you can specify in the chat. Again, you have some time to reflect on this. So let's have a look at the results. 30% use presentations. 13% infographic, 20% posted on the organization's intranet, 10% use the organization's social platforms, 23% at meetings with clinical groups, and 5% others. So now we would like to give you some tips to provide feedback. Although the ideal design for audit and feedback intervention depends on the recipient, their context and the targeted behavior, best practices can be guided by theory and evidence. So here are some tips to optimize the way you give feedback. The first one is ensure the data are delivered both written and verbally, and that the feedback is delivered by a trusted source. Also, it's important to include explicit targets in your feedback and, if possible, compare the data with relevant peers. Here we can also refer to some of the principles of persuasion of Dr. Cialdini. Based on research, she has found that there are 6 major factors or principles that, when employed ethically, increase our ability to build and maintain stronger relationships. So one of these principles is authority. We tend to follow people who look like they know what they are doing. So using a figure of authority to deliver your message, for example, a clinical champion, rather than having it come directly from you, is a great way to influence people. For example, as I said, a local champion. Another principle is consensus. Simply put, people want to be part of the majority, not the minority. When people are surrounded by others who are all doing something, they want to reflect that. And then the third principle I want to refer to is similarity. It's about trying to connect with people as authentically as possible in a way that they can relate to and identify with. So people feel validated and are more influenced by something or someone they observe to be similar to them. Another important factor is not to wait too long to provide feedback after the audit was conducted. So provide timely feedback, and it's important to keep the momentum going. Make sure there is a continuous improvement, monitor the impact of your audit, and feedback again if necessary. So don't overwhelm your target audience with an overdose of information. Provide fewer metrics and only data for the most relevant indicators. Aim for a simple presentation to avoid misunderstanding. A picture says more than 1,000 words and it reads a lot faster. All the more reason to visualize data, but beware, not every graph or table communicates equally well. So data visualization is a graphical representation of information and data, and the goals is to communicate this as clearly and as effectively as possible. Even if you've done your audit perfectly, if you don't give good feedback on the results, it won't have as much effect. So it's important that the recipients receive and understand your message so they can click the trigger, reflect on the desired behavior, and hopefully also adopt it. Here you can see a pie chart on market share. So a graph in 2 dimensions, a circle in this case, is more difficult to understand than 1 dimension. So in this pie chart, we tend to look immediately to the yellow part representing Verna. Now have a look to Sunny. If Sunny 2nd, 3rd, or 4th position, it's a little bit difficult to see, and to be sure, you need to read the percentages, and reading costs a lot more time. However, with a bar chart, we can see immediately that Sunny is in the 3rd position, and the design of the graph helps us even more to understand this. In the right graph, the title tells us clearly what the message one wants to communicate, and it's also supported by the yellow color in the title and also the yellow color coming back in the graph. Also, fewer colors are used to make the focus clear. So the choice and design of the graph makes it easier to understand the message more quickly. The key is to think first about what you would like to show. This will determine your choice of graph. So there are plenty of graphs. How should you choose your graph? We will go over this briefly, but if you want more information, I strongly recommend you to have a look to this very nice website where you can get a free poster or PDF of an overview of the different charts and when to use them. So here you can see an overview of the different types of graphs. The first one is comparing categories. When you want to show a comparison between categories A and B, for example. This is used when you want to compare nominal data, for example, hospital care units and so on. Then another category is change over time, when you want to show the change of category A and B over time. Then we have part to whole, when you want to show how A, B, and C add up to a total of A, B, and C. Then there is relationship, when you want to show how A, B, and C relate to each other. And distribution, when you want to show how often A, B, and C appear in the dataset. So once you have chosen your graph, it's important to be attentive about the design of your graph. So here are some tips you should try to apply. The first one is show in the context, the relevant ranking. Rank your data in relevant ways so the patterns and outliers become visible. For example, the category other you could place beneath. Then another one is target or benchmark. Enrich your chart with targets or benchmarks to give the values more meaning. Here you can see this with the gray columns behind. Then visual hierarchy. De-emphasize all non-data elements like axis and legend. The data is more important, so really only put the necessary on the chart. And highlight the most important element to make it stand out. Another one is support easy comparison. So when you have, for example, more than 4 series, change your chart to small multiples to keep the overview. And then another tip I can give you is show and tell. It's important to have a descriptive title, create a title to name the insights in the chart. And you can also use annotation. So you can use labels and annotation to help your data tell a story. Also, I would like to show you some don'ts. So avoid a misleading design. For example, multiple y-axis that can be very confusing and give a false meaning to lines crossing or the space between lines. Then you have to try to avoid too much color and also try to avoid 3 dimensions because it's less clear. Your message will be less clear and it's confusing to read. So I would like to quote Edward Tufte. Every bit of ink on a graphic requires a reason, and nearly always that reason should be that the ink presents new information. So really think about what the focus is and only use ink to express this message. Be careful with tables. It might look like a nice overview, but it takes more time to understand the message. At the right, you can see how you can narrow the focus so it's easier for the target public to understand your message. To illustrate some best practices of data visualization, I would like to show you some graphs of the audit results that my colleague Linley presented earlier. So you can see the original table above and the suggested graph beneath. So first we want to show how many patients are attending the preoperative clinic in time. This graph shows well how the different categories sum up to a total of 100%. And the colors in the title mark the most important words and are related to the color in the graph. With the color scale green, orange, red, it becomes also clear what is the targeted behavior. Then we want to have a look to how many patients had FBA in time. So in total, there were 30 patients included. If you look to the table, the sum of the three percentages is more than 100. So it takes some time to understand how these three are related to each other. And in the graph, it becomes clear that 13.3% didn't have any FPE. To make the story complete, you can make an annotation. This is done, for example, in the gray beneath the graph. So the number of patients with results available on the day of pre-op assessment. So this makes the story more complete. In this graph, we want to show how many patients were anemic and then how much were treated for anemia. So you have the different categories: anemic, non-anemic, and no pre-op assessments. And then in the bar of anemic, you can have a look in the colors, like red is no treatment, green is treatment. And then a gray annotation to clarify that of these anemic patients, there were only 4 patients documented as part of the pre-op assessment. And then if you have a look to were treated for anemia, there was 1 who was treated with oral iron, 1 with IV iron, and 2 had a pre-op transfusion. Also interesting, from these 4 people, there was hemoglobin remeasured after pre-op treatment in only 1 person. So this is a way to visualize the results of your data, and to make sure the message is understood well by the public and understood easily. So here you can see that it's very important to have a change plan. Try to address reactions to feedback, identify barriers, and enablers to practice change. Of course, it's important to include SMART goals, and you have more chance to have a good result with your feedback. I mean that there will be a change if you also suggest an action plan. So it should be SMART, specific, measurable, attainable, relevant, and time-bound. And it's very important to include stakeholders when planning this change to see what is, for example, attainable, realistic. And in this way, you can increase engagement and adoption of change. So now I would like to pass back to Linley.
Thanks very much, Jana. I'm not sure if you can hear me. I've got a little Wi-Fi sign. It's all working. Okay, good. So now we're looking at some of the possible changes. So now that we've seen the data, we now need to try and help address some of those issues that have been identified, and Jana showed us some good ways in which we can present that data. So with the support of the Blood Management Committee, the TP can lead or facilitate some of these possible changes. Now, these are just possible changes. You might like to do other different things. So setting up a patient blood management committee to develop and to drive the change is a really good point to start, particularly when you're trying to implement patient blood management. So you could also make sure that you broadly educated everybody about the results, so about the current issue that you actually have at your health service and why it's actually important to address anemia. So For the Patient Blood Management Committee here, we've got some examples of who could be involved, and so it needs to be multidisciplinary. And when we talk about physicians, we mean to have good representation of those right across the organisation. If you've got someone who's a specific champion, bring them on because they can bring along others. And in education, education could be face-to-face to large groups. And Jana, if you could put the education, thank you. So there could be face-to-face presentations to large groups or to smaller organisations at handover. You could use the freely available online education tools such as Blood Safe eLearning Australia or resources from the Australian Red Cross Lifeblood. So the next step that you could take could be mapping your current surgical workflows with stakeholders. So here you could, the next slide please, that you could see by mapping the process from the time of decision for surgery right through to surgery, you could actually see where there may be some gaps or where there's some opportunities that you might be able to implement some processes that could look at assessing patients for anaemia. Once we've actually developed or done our process map, we could look at developing an assessment or management flowchart. So with the support of the Patient Blood Management Committee, the TP and the surgical stakeholders, and in this setting it would be the orthopaedic surgeons and their anaesthetist, the nursing group in their perioperative clinic, could look at what the roles and responsibilities would be in relation to anaemia and iron deficiency assessment and how those roles would be followed up and how the management would be undertaken. So now I'm going to show you some examples of anaemia pathways that have been used and they're currently readily available. This flow chart actually shows you in different colours the responsibilities of each person's role, so you can clearly identify where people's responsibility lies in relation to their process map. We've got here another example. And you could actually use this and highlight specific areas of someone's roles and responsibilities. Remembering that any process that's developed to support patient blood management should be sustainable. If you can include processes within your existing workflows, it does give a greater chance for initial and ongoing success. So it's important that these processes don't rely on a specific one individual, but they're actually inbuilt into the process. So anyone fulfilling the role could undertake that. But that's not to discourage any individual enthusiasm, because the more you have enthusiastic people, the more engaged people will become. Got another couple of examples here of flowcharts. The first one is looking at anaemia assessment flowchart, so about the screening process and where it should be done. And then the next example that we've got here actually shows you, once you've got the results, what the management might be and how you might manage those patients. So depending on the level of change that you're going to be undertaking, you may need to provide a business case or a cost study to support the change that you want to make. Our Australian Red Cross, our Australian Blood Matters program actually has a template that you could use and adapt for your own individual use. The business case needs to outline the expected benefits of the program that you're wanting to implement and how better anaemia management is going to improve patient outcomes and possibly reduce the length of stay, and whether it's a cost benefit or cost neutral. The TP can actually play an active role in the development of these cases, and once approved, then they would also be playing a vital role in the implementation of the change, because they have a really good understanding of the organisation's processes. Following steps would be the implementation of the flowchart, and that in itself would actually require a whole plan, PDSA cycle. To measure the effect, you would need to re-audit at specific time points and report those findings. And that then would subsequently lead to the next PDSA, where you might want to expand your anaemia assessment to the whole hospital or in a stepwise process to another surgical group. Each one of these steps, you would have to use your SMART goals and determine your parameters. And this would all be done with your Patient Blood Management Committee. And of course, you'd need to report your findings. Now, change management is very big part of this, and change management in itself can be a whole session or a whole day, really. So this is just a quick reminder to you that change takes many stages, and as we can see here on the Kubler-Ross change curve, people can actually be anywhere on this change curve, and we need to acknowledge that change takes time, and it needs to be reinforced and revisited many times, and people need to be encouraged to take the lead, and this is where the TP can be involved in actually just reinforcing and re-engaging with people. There will be challenges along the way, but having a good patient blood management committee can help you provide the support, and your TP can also help to provide engagement across the organisation. So today we've taken you on a quick look. We've done an audit for what you could consider. We've collected the data and how you could present it. We've shown you some examples of what change you might want to implement, and we need to acknowledge that change takes time. Be patient and keep encouraging others. We need to engage our early adapters in change and get them to encourage others and to bring people along. And if you listened to Lisa Escort's presentation earlier on, it was about also using examples or exemplars of good practice and share your wins that you have with others. So now I'd just like to I think we've got Rachel online, if she can come online as well. Just to show you that you can contact any one of our Transfusion Practitioner Forum members here. There is a comprehensive list of resources that are available in our description section of this session. So please download that. There are a lot more available. We've put the ones in there that you might like to actually look at and view. We've used clearly a number of references for the process. And now we can open up to any questions, if there's any questions that are there. Also, just a reminder that if you've got any suggestions for any further interactive sessions with the transfusion practitioners, to add them into the chat or to the Q&A so that we can keep a record of that. If we happen to run out of time in the session here, there will be a post-session discussion forum where we can answer further questions if you'd like to do that. So, have we got any questions there today, Rachel?
Nothing's come up on the chat. And nothing's come up on the Q&A yet, so you never know. We've still got another 4 or 5 minutes. And so while people are having a think, it's more of an observation, really. In my almost 20 years of doing the job, I've noticed more and more that people want the data and the evidence for change before they'll do anything. So you can't just say this is best practice because this is a guideline. People now want to see, how do you know, what have you collected, what is everybody else doing? The most common question I get is, if we do this, what's everybody else doing? Would you both agree you've come across that more and more is required of us to show why we want to change and why it's good for the patients?
Yes, I'd agree with that, Rachel. People need the evidence of why it is important. They also probably need the evidence of that they actually do have a problem as well. So that's where those things run hand in hand, and that's where all the peer review literature can really help us, particularly in this area of anaemia management, where there's a lot of information there about that, that if you can then provide them with what is the best practice, this is where we have a problem, this is the evidence that supports that, how can we in our organisation aim to be at one of those best practice points? I think, yeah, that is a really important thing. And I think it's one of the things we mentioned earlier, is making sure we've got the evidence, and particularly anemia, there's a lot of stuff.
Jana?
I've also seen that when you present data graphs, that the clinicians, they are motivated because they are confronted. They can see what is actually going on, and then they say, oh, I didn't know that it was like this, and then they are triggered to make the change. So yes, I think it's really helpful. And
I think what we've mentioned before, Jana presented in some of her stuff where we can possibly do peer comparisons. I think that's really helpful. I mean, sometimes clearly you need to be a bit careful about how that is presented and the data that we are presenting. But we often do that with our audit results here from our Blood Matters group, is that we compare them with their peered hospitals. they don't know exactly they know which hospitals are in the group, but they don't know exactly which one they're being peered with. And then it gives them a good example of where they're sitting. And it also shows then if we can see one of those hospitals is actually doing a really fabulous job, that we can then go to them and say, well, what are you doing? How did you implement that? What can we use? So I think it provides that option as well.
Yeah, it's definitely becoming far more important. And I think audit and data now are hand in hand for the transfusion practitioner, whether you're using other people's tools, which is a great thing to do, so you don't reinvent the wheel, using other people's data to compare against, as we've said all along. I think for our arsenal of affecting change, this is a very good thing to do. And I love those slides, Jana. I think the example of a pie chart versus the bar chart just beautifully sums up just how your eye is drawn. And I think something so simple, because it's very effective, which is what we want to do.
Yeah, and I think sometimes we try and over expand it, which Jana showed doesn't work.
It's good to make it easy, not to complicate it.
Yes.
And it's not difficult to apply. Everyone can do it. You don't have to have, I don't know, university degree to understand it. It's really easy.
Really straightforward.
And it's really great to see that there's some freely available tools. Like I didn't realise those tools were available until Jana introduced me, and so that's then it gives you just a really good way of presenting things. So, like Rachel was saying, don't invent something if there's already something available. Use it and just acknowledge where you've got it from, and use it freely. All of us TPs are happy to share anything with everybody else.
Right, we've got 7 seconds, so let's join the discussion room for anybody that'd like to carry on.
Thanks, everyone.